Thank you so much for joining. We're going to jump right in. My name is Kate Shea. I am the Senior Manager of Clinical Programs at NCSD. And before I introduce our fabulous speakers, I just want to highlight some of the things we'll be talking about. We'll be doing a panel discussion today. We're going to spend some time highlighting some important work being done on the ground in Minnesota. And then in our panel discussion, we're just going to talk about the workflow, implementation, and overall value of rapid testing and improvement of linkage to care. So I'm going to go ahead and introduce our speakers and we can get started. So first we have Rye. She is a peer recovery specialist for the Substance Use Response Team in Duluth, Minnesota. Substance Use Response Team, or CERT, is an entirely peer recovery run-led diversion and deflection program housed within the Duluth Police Department, serving 3 counties in Minnesota as well as the city of Superior, Wisconsin. Thank you so much for being here, Rye. Jesse has worked in the field of harm reduction and prevention since 1989. He currently works at St. Paul Ramsey County Public Health as a health educator working at the Syringe Exchange Program for Ramsey County out of Clinic 555. Jesse worked at the Minnesota Department of Health for 23 years as a disease investigator, where he conducted hundreds of interviews with people that had tested positive for sexually transmitted diseases, assuring that all who tested positive for STDs were treated. He also connected all HIV positives into care and conducted STD testing in the field. Thank you so much, Jesse. And finally, I will introduce Rebecca. Rebecca is a seasoned professional in healthcare diagnostics, currently serving as the Director of Infectious Disease Diagnostic Sales with OraSure. Rebecca has led initiatives to enhance diagnostic capabilities during the COVID-19 pandemic that has extensive experience in public health and infectious disease diagnostics, including syphilis, HIV, HCV, significantly contributing to public health advancements and disease prevention across multiple organizations. And thank you, Rebecca, for being here with us. So before we get started with a couple of presentations, I would like to just launch a quick poll. So go ahead and answer that first question for me. Are you currently using a rapid test for HIV, HCV, syphilis, or all of the above? And thank you for chiming in the chat as well. We love hearing where you're coming from and what you do. Okay, got a lot of responses. Awesome. Oh, and you know what? The other 2 questions popped up there, so please do just let us know your thoughts on those as well. Obviously, we're going to be talking all about rapid testing for HIV, HCV, and syphilis today. And with that, I am going to turn it over to our first speaker, Rye. Let me just pull up presentation here. All right, Rye, go ahead. You have the floor.
Thank you. Hi, everyone. Like Kate said, my name's Rye. My pronouns are she, her, hers, and I'm a peer recovery specialist with the Substance Use Response Team. We can go to the next slide. So, like Kate had said, I work for the Substance Use Response Team. We are an entirely peer-led and run harm reduction-based outreach program embedded within our local police department. We serve all of St. Louis County, Carleton County, Lake County, and then the city of Superior, Wisconsin as well. So there are a bunch of services that we offer. We have 4 peer recovery specialists on our team and 1 mobile LADC LGSW who also has the capacity to come with us, whether that's overdose follow-up with survivors, or completing comprehensive assessments for folks who are interested in getting into treatment. And so those are just like a few of the things that our team offers regarding services, in addition to providing rapid STI testing as well. So just a quick overview of the STD rates for all of Minnesota. In 2019, Minnesota saw 275 new HIV cases that were reported to MDH. And it was estimated that there were about, or are about at this time, 9,193 people living in Minnesota with HIV. And compared, like if you look at 2018, in 2018, there's 286 cases that were reported. However, if we look at 2023 and compare those two numbers, we see that there's been an increase in cases. So in 2023 for HIV, for all of the state, we were up to 324 cases reported and an estimated 9,996 individuals living in the state with HIV. Between 2019, and maybe Jesse can speak more on this, I think it was 2018 or 2019 for Ramsey and Hennepin County. So 2019 is when Duluth officially declared having an outbreak, which is where I'm located. And we had cases confirming or dating back to that time. And then Hennepin and Ramsey counties declared an outbreak 2020 with cases dating back to 2018. So that's just like a little bit of side information regarding HIV with those. And then for hepatitis C, in 2019, there's an estimated 32,707 individuals living within the state who have hepatitis C. 2023, there's an estimated 31,942 people living in Minnesota with hepatitis C. So we can see that our rates kind of decreased there in that 5-year span. And then looking at our syphilis cases, 2019, we had 1,127 cases that were newly identified. And this was a 23% increase compared to 2018. And then in 2023, we have 1,748 cases that were newly reported to MDH or Minnesota Department of Health, with a 5% decrease from 2022. We can go to the next slide. Can we do the next slide, Kate? Thank you. I think did we skip one? So looking at greater Minnesota, so that's the counties outside of the metro area, and giving y'all a little bit of an idea too about what our rates are outside of the metro. For HIV in 2019, we had 53 cases in greater Minnesota, or in 2019, we had 53 cases in greater Minnesota. And then again in 2023, there were 68 cases reported for the areas outside of the metro. Looking at hepatitis C, so we currently, or I don't currently have the data for that going back to 2019, but I do have the data looking at 2023, and it was estimated, or it is estimated that there are 13,948 people residing in greater Minnesota who have hepatitis. C. And then syphilis in 2019, we had 121 cases, which is a 104.2% increase compared to 2018 for Greater Minnesota. And then in 2023, we're looking at 119 cases for that. So a quick look at testing sites. Because I'm embedded within the police department, we don't have a separate area where we can do like lab test or confirmatory testing or have folks like come in and make appointments to do testing. A lot of the testing that I do within our team is I meet folks wherever they're at. And whether that's like if they're getting an assessment done with our mobile assessor, I'll bring my testing supplies with, and I'll talk to them and kind of gauge like if, you know, and see if that's something that they're interested in or want. But I also have, you know, a couple testing sites where we have days and times specifically throughout the months where we offer testing. So the downtown Duluth Public Library is one of those places, and we do partner with a local organization called the Harm Reduction Sisters. And there we offer rapid STI testing for hepatitis C, HIV, and syphilis. And then we also have non-medical case managers on site to talk with folks if they're interested. Another place where I have those days and times set up for continuous testing to offer to individuals is at NERC, which is also known as the Northeast Regional Corrections Center. And so I meet with folks there who are interested in testing as well. And from there, you know, we offer an array of services too. So those are kind of like our three main venues or ways that we offer testing within our team, but also like we do a lot of street outreach. So if we have contact with folks that we're talking to out on the street, we visit a lot of encampments sometimes as well. And conversation will just come up organically. And if they want to be tested, we can do testing outdoor. We can tell them about testing at the library and they can come to the library. We have, you know, a couple different ways that we can provide testing too, so it doesn't have to be outside. And then, like I said, again, we do in-home testing as well. So if we're going to somebody's house to do assessments, I bring my stuff with, and we can do it within homes or like transitional living spaces as well. And then I just included a picture on the slide to show y'all, like there's our public library, that brown building with the blue lines is NERC. And then below that is just an image from Harm Reduction Sisters showing some of the things that we offer when we do provide testing. So all of our testing is incentivized. So we give out like gift cards and bus passes, but also we talk to folks about addressing needs if they have them. So offering condoms, fentanyl and xylazine testing strips, Plan Bs, clean syringes or referrals to local SSPs here in our area if they need, you know, clean cookers or needles, safe use items. We offer clothing, hygiene products, food, and then also do linkage to care as well when we test. And that is all that I have to share with y'all about testing with CERT and myself. Thank you.
Thank you so much, Ray. I'm really excited to hear more about the work you're doing during our panel discussion. Jesse, I'm going to have you review your slides next, and then we'll move right into the discussion.
Thanks, Caitlin. Ray, I don't know if I could follow all that information, but you had a lot to share with us, so thank you. This is my name's Jesse Saavedra. I work at Ramsey County Public Health. I'm one of the health educators that work here. We're on a small team of individuals that do a lot of testing either in our clinic or we're out in the community. We're fortunate to work closely with an STD clinic that is right across the hall from us. And when we come across individuals possibly that are positive, we're able to make a connection right away to the services that we provide here. The picture that you're seeing right now is a mobile van that we purchased in 2022, and we had it retrofitted so that in 2023 we had this van going out into the community, going out to encampments, shelters, drop-in centers, health fairs, and there's the ability to do testing within. This van was purchased through Title X funding, where we have the availability to do telehealth through this van as well. So it's a really nice service that we're able to bring out into the community. We're actually getting it repaired again so that we can do more services and getting it out into other communities as well. Next slide. This is kind of a picture of two different sites here. The picture to the right is our past syringe exchange program. We had a small little office, and this is in 2018, where we were providing all our syringe exchange services through that portal. And then in 2018 is actually when MDH declared, an outbreak of HIV and syphilis. And so it was unfortunate at the same time we had the pandemic because a lot of places were getting shut down. They were told that they couldn't operate it. So we were fortunate to have a medical director that said, you know what, if you use proper PPE, let's keep our doors open. The community are the individuals we need to provide services to. So we ended up setting tables outside. And the shot to the left are a couple of individuals getting a couple of rapid HIV tests. And for probably a year, if not longer, all our services were provided outside because of having to wear protection, having to wear masks, having to make sure that we took care of not just the community, but ourselves. And that was really important because we didn't want to stop our services. We wanted to continue to provide services to everybody in our community. One of the biggest pieces of this opportunity was opportunity to share what was going on. A lot of the individuals that came to our doors were saying, what's going on? Why is everything closed? They were unaware of the pandemic. They were unaware of what was going on around them. So we, at the same time, weren't just providing testing, but we were providing resources for treatment, for testing, for COVID, anything and everything that related to health. They would trust us to ask us how they could provide or how they could access our services. And as I mentioned, we have a great nursing staff out of our our STD program that are willing and most often able to see somebody when somebody shows up. A lot of the services we do are in-house, but we go to encampments, such as Ryan was mentioning, a lot of shelters, a lot of drop-in centers, and we also do testing at treatment facilities. So we're able to go to a lot of different places because of the staff we have that are all dedicated to providing the great work that we can do to the community. We only wish that we had more staff to be able to do this because we can't get everywhere. That's the unfortunate piece about it. When we purchased the van, we started to get people asking us, can you bring the van here? Can you bring it there? And unfortunately, that's not something we can do yet. Once we get more staff, hopefully we'll be able to do that and start providing more testing out in the community. We went to one of our site in Greater Minnesota, Austin, Minnesota, for example, probably about a month ago. And it's a 2-hour drive from St. Paul. And we went there to do testing. We probably provided about 150 tests along with a couple, 3 other agencies that work in the field of harm reduction and SSP and testing. Next slide. So this is a slide of years past. So in 2018, we received that notice that there was an outbreak. So we started to do more outreach and encampments. That's why in 2019, you see a rise in numbers. There was 134 numbers of positive HIV AIDS diagnosis in Hennepin. And the yellow line dictates the highest rates. In 2021, it was still high, and actually in 2023, they're still high. Ramsey County, which is where I'm at, is the blue line, which is the second highest from that above. 2019, we did more screening. We put our PPE on. We went to the encampments. We sat down on buckets, sat down on curbs, and we just did mass testing. And it was so beneficial to our community because we had already established a relationship with our community by doing needle exchange prior to this. And so then when we came back to the encampments, asking them if we could come in and invade their space in a sense, we were able to empower them with more knowledge of really why we were there. And then we were able to do more testing. We were able to access a lot of individuals that normally would not go into any clinic for testing for that matter. Next slide. Here's a slide of cases of syphilis in co-infected with HIV over time. As Ryan mentioned, there was a 5% drop from 22 to 23. Most cases were MSM. In 2023, 30% of the early syphilis cases were among women. And that's a record high as far as syphilis cases are concerned in regards to positive cases for women. And these are primary new cases. Next slide. Now, I need to actually mention, though, one of the things that was not mentioned in the previous slide, congenital syphilis. In 2019, there was 21 cases. And in 2023, there was 29. In 2024, we have so far 15 congenital cases of syphilis. And we're really worried about this because we're feeling that it's going to surpass last year, of course. So we're really doing a lot of work to see what we can do about this. This is a slide of, as it says, number of syphilis cases over time in Severn County metro area. The highest peak we had was in 2022. And again, that was in Hennepin County, partner city of Ramsey. And then we, of course, Ramsey is the second highest line there as well. Next slide. This is acute hepatitis. This is hepatitis A, which is the blue line. Hepatitis B is the yellow dotted line. And then acute hepatitis C is the gray line. And as Ryan mentioned, she kind of covered a lot of the numbers in this already. But, we're thinking that there's assumed 31,000 people still living in Minnesota with chronic hepatitis C. A lot of people that we test for hepatitis C at the encampments or at the shelters already know they're positive. And but they're still getting tested. Now, one of the difficult pieces is getting somebody in to get treated for this. A lot of people think, and they've heard these rumors that it goes away on its own. Some people it will, but not everybody. So it's really difficult for us to get individuals in. But if we do get them into our clinic, we most often can get them started on meds so that they can be cured from hepatitis C. That is my last slide. So thank you so much for letting me spend some time with you.
Thank you, Jesse. Appreciate you so much and the important work that you do. We're going to roll right into the panel discussion with the three of you. Before we get started, just a reminder, please do utilize the Q&A box. In the case that we don't get to questions at the end, because I know that we're going to have a really robust discussion based on those presentations, we will be doing some follow-up. So you will have access to this recording, and we would love to follow up on any of the questions that you have and maybe have our speakers answer them offline. So please do utilize the Q&A box. We are going to get started on the first question. And we'll start with Rye, and then we'll just kind of go around to all our speakers. So Rye, how does rapid testing tie into a syndemic approach for syphilis, HIV, and HCV screening?
So I think the way that it ties into screening for all three of these is it allows us to like I said before, meet people where they're at. A lot of folks that we work with, predominantly, like, and when I say we, I'm talking about CERT, are people who use drugs. A lot of folks who are unhoused, and then folks involved within the criminal justice system. And so we're able to meet with them where they're at, and talk with them and help them kind of address needs or concerns that they may have. And I think, you know, some of the barriers that a lot of our folks face are things like transportation barriers. They can't get to a clinic that, you know, is low cost or has sliding scale fees because they're uninsured or underinsured. There's, you know, a lot of folks we know and work with don't have phones, don't have a place to keep their medication. Like I said before, it's like don't have insurance or are underinsured. And so because this testing is free, we provide it free. We're able to meet folks where they're at and then help work on these things with them as we go along. Also like bringing them to appointments, stuff like that.
Thank you so much, Rye. And Jesse, I'll kick the question to you as well.
Thank you. For me, I think it's one of these things of empowerment. Being able to test somebody for all three infections at once, you know, it gives that individual that we're talking to that opportunity to understand the importance of why. There's so much misinformation out there. You know, if I'm doing my job right, I'm going to take the time and listen to somebody. And then I'm also going to help them understand what syphilis is, what hepatitis is, transmission routes, and then of course what HIV is. You know, we've had rapid testing around since I was a DI in '95, and it was great at first. You know, you had the swab for the Orcher. I remember using that. And then eventually we got the finger pokes, and that was even better for individuals because it was less invasive. People were kind of, oh, I can do that, you know, just that little bit of blood. And then the results came back so quickly. People appreciated that. These are additional tools that all of us that work in the community are so important to have access to because, as Rye mentioned, you know, it gives a person that normally would not go into a clinic a choice, an opportunity to get a test done, whether it's for a gift card or not. Most often it is because of the gift cards, but that's also a good thing because, you know, we're finding people out there that individuals that are positive for infections that had no clue, that maybe have had syphilis for 20, 30 years and didn't even know it because they've never been tested, even though they thought they were tested. So these are things that are so key for us to be able to give somebody a result on the spot. And then if they are in need of treatment, we can either work with them to get them in or give them choices of places that they can go to provide services for themselves. And me not being one to say, this is good for you, this is what you need to do. It's being able to say to somebody, these are the resources we have available. I also can bring you somewhere today if you want to go with us. So being able to do that is so key in the community that we're working with. Thanks.
Thank you, Jesse. And then Rebecca, you can go ahead with the same question.
Absolutely. So Ryan and Jesse have really nicely set the stage for some of the things that I wanted to mention. And essentially that being that we're currently in a syphilis crisis. We're seeing the highest rates of syphilis in our lifetime, plus a rise in STI rates overall. We're seeing some nationwide imperatives from several organizations that are focusing on rapid testing and a syndemic approach. And I'm thrilled to see a lot of names in the chat that I know are taking this approach as well and doing quite a bit of testing. One of the goals, as Raya has referred to a couple times, is to meet people where they're at, especially in the case of those who don't normally seek routine healthcare. And I've heard it with both Jesse and Rye, corrections, emergency departments, community outreach, shelters, substance use treatment programs, to name a few. So one of the benefits of the rapid point of care tests is that they have high accuracy. We've got ease of use, a small sample size, and a quick time to result. So we're able to get results to a population that may not normally get tested and quickly start treatment and or link them to care. The CLIA Wave point of care test can be performed by trained non-clinical staff, which makes them an excellent option for community-based organizations that are out in the field. I've seen the mobile vans out there, and that's fantastic. Historically, we do tend to see that as the number of rapid testing programs rise, mortality rates decline. So granted, there are additional factors, but the increase of accessible testing and treatment has played a significant role in the decline of HIV and hepatitis C mortality rates in the US. My sincere hope is that with the increase of rapid syphilis testing programs, we'll also see declines in congenital syphilis cases and stillbirths. As congenital syphilis cases in the US have risen by 755% from 2012 to 2021. With the CDC's also stated that there's 88% of the congenital syphilis cases in 2022 could have been preventable with timely screening and treatment. So, I'd love to see a greater impact in that space. And I know there's been updated ACOG recommendations released earlier this year that also call for syphilis screening of all pregnant individuals, not just at risk, but all pregnant individuals during their first prenatal visit, during the third trimester, and at birth. One case of congenital syphilis is one case too many.
That's such an important point. Thank you, Rebecca. So for our second question, this is going to just go to Rye and Jesse. And I know that, you spoke about doing some work with the library, and there's been a lot of interest about that in the chat as a great way to provide the community with resources. So how does rapid testing allow you to reach different demographics? And could you share any challenges or considerations for the populations you test? And Rye, you answered first, so let's go with Jesse to go first this time. Actually, it looks like Jesse might be frozen. So Rye, I'm going to kick it to you to start.
Okay, yeah. So I guess I could just kind of focus on the library and NERC because the two are very similar, but also very different at the same time when it comes to like demographics and who we serve. So looking at the library, when I offer testing there, it opens testing up to everybody that wants that service. It doesn't have to be people who are unhoused or people who use drugs or people who, like or sex workers or people who have like just mental health. It's really opened up to everybody in the community. And that's kind of what we see come in when we do the library testing, which is amazing. But also because it is the center of our city, it's an easy place to access by bus or foot or bike. And it's where a lot of our folks go, especially in the wintertime. It really is a place that's easy to meet at and be able to have like a private area in the library to be able to perform testing there. As far as NERC with the demographics there, so individuals who are incarcerated at NERC come from not only Minnesota, but also Wisconsin as well. And they're from like all across the states. And so and sometimes when our county jail goes into overflow, they will send folks over to NERC as well. And so we see folks from all over the place coming in and being really interested in getting tested. And I think the biggest thing that I hear, and one thing to just like kind of take into consideration is that like there's still so much stigma around using drugs, people who are in recovery from, substance use, and then also STIs and getting tested, right? And so that is one thing that like I've noticed a lot, especially like with my folks at NERC, is that a lot of them have said like, I've never been tested before. And the only reason why I'm doing this is because I'm here now and like, I want to know what's going on. How can I make changes going forward? But at the same time, like I've heard over and over and over again, a lot of folks say, well, whatever I have and I deserve this. And that's not necessarily true. And so there's a lot of conversation and education that goes into not only the testing portion with the folks who want to test, but also the community and getting established in these places and offering these services. I think the biggest challenge that I faced or have faced in the past with getting testing started is getting community organizations on board and explaining like why this is such a crucial and beneficial service for our community members. But also I think the other challenge is like being able to follow up with folks, especially if they're unhoused and don't have a way to be contacted at all. So a lot of my folks, if they're not within St. Louis County or even Duluth as the city, it can be really, really hard to follow them and follow up with them, especially if they end up, being released or going to treatment somewhere else and they're not sure yet. So I think that would be like my biggest challenges and some considerations to take in. Yeah.
Thank you, Rye. And Jesse, I think maybe you froze for just a minute while I was asking the question. Did you hear the question or do you need me to repeat it?
Do you mind repeating?
Yeah, for sure. How does rapid testing allow you to reach different demographics? And could you share any challenges or considerations for the populations you test?
Thank you. So challenges first, and Rye covered that. It's so key for us to know when we go to an encampment. Here in Ramsey County, we're fortunate to have some teams that will give a notice when they're going to close an encampment down. So it's not like we're there one day and then we go there tomorrow, they're gone. We'll know usually a week or 2 weeks ahead of time. But probably 2 or 3 years ago, it was different. We go to encampments, do testing, we might find a positive, and then we go back and they'd be gone. And so it was really difficult to get somebody into care because of that. We were able to develop some relationship with law enforcement and with some of the housing to say, you know what, if you're going to close them down, we need to know because of, and we kind of give them a situation, not tell them why, but just kind of a situation of what's possible to happen. Those are one of the biggest challenges. The other two, for example, is if we have somebody positive for syphilis, getting them in for one shot, if we were giving incentives for treatment, we might have them come back for the second or third. Sometimes they come back for the second or third, or they wait 3 weeks and then they have to start all over again. So we run into those issues because people are moving around a lot. And as Rye mentioned, we can't find them to get them back into treatment. There was a case a couple of years ago where a nurse and I were going to encampments left and right to finally find somebody that we were able to get on 30 days doxy, because that was the only way this person was going to get treated, because they did not want to come in for the shots. I think those are really one of the hurdles that we really have. Being I'm not a nurse, I'm not a doctor, I'm only a health educator. If we were given those opportunities to help people get treated, point of care, not just like a point of testing, point of care, if we were able to get people treated right on the spot, down the road, I hope our mobile van will have that kind of availability that will have meds on it. So if we run across a positive, we can start them in care right away. Not only in care for syphilis, but if they are at risk for HIV, we can talk about PrEP. We can talk about getting them into PrEP. We can start them on PrEP at that visit. So, that's just another segue that I think needs to be mentioned, because it's so crucial, because we need to look at prevention. We don't want to wait till somebody's positive before we start to help them. If we can start preventing people from becoming positive, that's the key. That's how we're going to save more lives. As far as our sites and rapid testing, we do testing out of our syringe exchange, and we'll test everybody that wants to get a test. But unfortunately, there are times where individuals take advantage of the $10 gift card. They'll come back every week and want a gift card. And some of us are kind of understand that, hey, this is what they're doing. But at the same time, we're not really clear of what this individual is going through or their risks. They might turn within that week's time. So I think it is important that you continue to do testing. At one of the encampment sites 2 years ago when we were out there, I was testing somebody. The nurse next to me said, I just tested him a couple of days ago. He ended up coming back positive. And when I told her that, she said, oh, shit, excuse me. And so it was kind of like, okay, we need to be more diligent about what we do, how we talk to individuals. And as I mentioned before, is the listening is so key, because there are things that are being said to us that if we're so busy trying to do what we do, we're not listening to what they're telling us. And I think that is another thing that a lot of us wear so many different hats in what we do. But I know for me, the listening piece is one key thing that I need to work more on, because of the fact I love going into the community. I love providing the services that we provide out there, but I need to continue to ask the community what they want from me. When I go with syringes and maybe water and those kind of things, somebody will say, hey, Jesse, when you come back tomorrow, can you bring me bandages? I got wounds, or can you bring this? And I need to remember that so that when I go back, I can bring them, because we're beginning to develop those trust levels with people so that we can do these kind of tests. Because at first, somebody doesn't trust you, they don't want to get tested. Once in a while, once you start developing that relationship, they're going to say, hey, by the way, you know what, I should do this. And maybe my friend down the way needs to do this too. Rapid testing helps us do all these things. And I think the more that we have available to us, and then the more that we're able to give incentives for some of the other tests, I think will help us actually reach more people. Thank you.
Thank you, Jesse. And some of your points are a great segue into our next question, just about testing workflow. And Rebecca, let's start with you this time. Just in discussion on current testing workflow, which we'll have Ryan and Jesse speak to, what are your thoughts on co-screening for syphilis, HIV, and HCV, which I know Jesse briefly touched on?
Yeah, and Jesse also mentioned something that I think is critically important, and that's that many seem to be unaware of how drastically the syphilis rates have risen across the US. So, I think adding in the importance of testing for syphilis while you have somebody at your, in front of you to test for HIV and Hep C is incredibly important. Syphilis, as we know, is known as the great imitator, and it mimics many other diseases. So while we've had a focus on testing for both rapid HIV and rapid hepatitis C at point of care, I absolutely think it's time to add rapid syphilis testing to that protocol. With the rapid point of care test, the benefit is that with one finger stick, you can collect specimen to run all three of the tests at the same time. And how you do that, how you create that workflow is really determined by what fits best logistically into the testing process for the organization or the mobile van or whoever's doing it. But you can start with running the tests that have a longer runtime first, or the ones that have a need for a greater specimen volume first, and vice versa. But I think it's just a bit of trial and error in terms of what fits best logistically.
Absolutely, thank you. And then Rye, we'll have you answer that one next.
Yeah, so for workflow regarding testing, how I kind of like start, or when I'm providing tests with folks, I just disclose to them right away, like, testing here, you will be tested for these three things. And I'll list like HIV, hepatitis C, syphilis. And, we do go through pre-screening process. So like if somebody has tested positive in the past, like we'll talk to them. And Jesse had mentioned this before, like some people will know that they're positive and continue to test because of the incentive piece. And what we have always kind of like said as a team with CERT is like, we are not in a place to decide whether or why, or get into the specifics of like why this person is coming in and not wanting to disclose that to us, but sometimes it'll come up organically And it's just kind of like, you'll still get an incentive, but we do pre-screen. And then like we talk to, a lot of folks too about like, you know, you will still get an incentive, like if you aren't going to test for these things, because let's just like educate and talk about these with you and give you resources if you need resources. So yeah, testing, when I provide tests, I usually start with my hepatitis test first, and then do syphilis while that's developing. And because our HIV tests develop the quickest, like you get results like right away. I usually do that last. And then if I'm still waiting on results from Hep C or syphilis, like I use that time in the middle to really talk to folks. Conversation runs so organically, like some of the folks that I talk with, especially thinking about like NERC specifically, some of them, like if they're, you know, not seeing other people outside of the facility a lot, like they have a lot of questions, they want to talk, they want to follow up on things, or maybe they're given wrong information, so they're going to ask and, you know, be curious about that as well. I think I answered all of the questions. Did I miss anything?
Yeah. Yes, thank you,
Perfect,
Ray.
thank you.
Okay, Jesse, then I'll turn it to you.
Thank you. So right now, HIV is the only test that we give incentives for. So of course, when somebody comes in, they'll ask for HIV. We do, or I'm going to say if I do my job right, I'll have them tested for all three. And why I say that is because we know that if I can do one poke, then it's going to be the accessibility. But then I need to, again, give that choice to them about that. But if I talk to them about, you know, what a symptom is of this or that, they might think more about it. You know, a lot of times people think they've been tested for everything. You know, and that doesn't mean much in a sense. And, you know, when you talk about sex to individuals, are they going to tell you everything that they need to tell you, or what you want to hear? So I have to remember, when I was trained as a DI, the trainers kept saying that everybody's going to lie to you about sex. They're not going to tell you the truth. So I have to keep that in mind, that, you know, I want to make sure that we're helping the individual in front of me and not what I need for myself. And so providing that information. Now, as far as how the testing goes, hepatitis C only takes a loop. So that's one easy one that you can do. You know, you have to fill a pipette for the HIV and for the Hep C. So, I mean, if I'm going to do them, if I'm able to convince somebody or talk them into it, I'll do a pipette, right? Or I'll do the loop first, and then I'll do the HIV and the Hep C. Really depends on the individual. They might not bleed really well. So if I'm sitting there trying to poke them more than once, I'm just going to say, you know what, let's do what we can today, and then maybe I can get you to come back tomorrow. You know, and sometimes they'll do that, sometimes they won't. And so I think that, again, information, choices, empowerment, so that they understand what's going on right now, and understanding the risks that they're possibly at, and knowing that we're only here not just for the gift card, but, you know, to listen to what they have to tell us and how we can better save their lives, in a sense, because if they're unaware of the situations or what they're putting themselves in, we again are the source of so much information for the people that we see. So I think being able to be there for them is so key for me. Thanks.
Thank you so much, Jesse. In the interest of time, I think we're going to run through our last question, what I think a lot of folks are curious about based on the chat and the Q&A. And we'll start with Rye. So could you share any best practices for someone looking to implement a rapid testing program?
Yeah, I mean, like my advice is just coming from, you know, being embedded within the police department and the program that I work with, but I think it is super helpful and beneficial to offer resources outside of testing, kind of like what Jesse and I have both mentioned before, like we have incentivized testing. A lot of folks have like financial struggles and barriers. And like, I like to think of testing as like, where taking some of your time out of your day, and like you have so much going on, and like if you need this, like we want to be able to help and support you no matter like what that looks like. But also offering things like I think it's very, very helpful to like have things on site when folks come in if they're in need. So like offering Plan B, offering condoms, having clean syringes or like pipes, safe use stuff. Having clothing, offering food, like if you have that ability to do it with rapid testing sites. I would also say, and like we don't have this, but like if you have the ability or the capacity to be able to do confirmatory testing, you know, where you can get those results and continue to like further follow up with people. Medical and non-medical case management is a big thing. And I mean, maybe having more than one person on your team to provide testing. So you have more people who, you know, you're able to provide more, do more outreach and like provide better and like services to those who are looking for it.
Thank you so much. And I'll have Jesse answer next.
Thank you. Best practices, access to resources. You know, if I'm going to tell somebody they're positive, I sure hope I have a treatment plan maybe in place for them. Or if they're not just positive for HIV, but positive for syphilis or any STD for that matter, knowing that I have a resource. I'm fortunate enough to work, as I mentioned, at Clinic 555. We have a team of nurses that are great, and they're always willing to see somebody and get them treated. We also have this great doctor, Dr. Keith Henry, who is an HIV physician, who is housed here as well. And if we have an HIV case, he's usually able to see somebody that same day. So we're able to have resources here available. So if you're going to start a program, if you want to do community work, that's great, but have resources available, and not just a list of resources, but a direct contact. You know, if I want to get somebody into housing, I hope I can call somebody up and talk to somebody personally and not get on a line, because we don't want to test somebody and then say, well, good luck. You know, I don't know what you're going to do next. We want to be able to hold their hand if we have to and bring them somewhere and get them into care or treatment. And I think that is so key, because there again, it's that trust that we're developing with the community that we're working with.
Thank you so much, Jesse. And Rebecca, go ahead and round out this question.
Yeah, so, you know, OraSure has been in the point of care rapid testing and infectious disease space for over 20 years. And we have a number of staff that have been with us for just as long. We've got the rapid hepatitis C test, which is just, it's an incredibly small volume, 5 microliter loop, as Jesse mentioned. And also our rapid HIV test, which has been through a number of enhancements in its lifetime, is also 5 microliter specimen, 5 microliter loop, and it can also be used with oral fluid collection at the same time. And then the rapid syphilis test, which is a little bit larger of a volume specimen, which is about 50 microliters, but you know, also a 10-minute test, so able to get results pretty quickly. I am incredibly lucky to work with a team of professionals who are dedicated to making an impact and saving lives. The team that I have at OraSure has a wealth of knowledge and diverse backgrounds. We have former state STD directors, public health program directors, laboratorians, RNs, community advocates, the list goes on. So, you know, our team is skilled and eager to support organizations wanting to implement a testing program, from providing guidance to CLIA waiver application, to logistical workflow, to test training and certification. With the number of years that we've been in this realm, we've created a substantial network of support partnerships and contacts. I know HHS has formed a syphilis and congenital syphilis task force, which in May released considerations for the implementation of point of care tests for syphilis. It's an excellent resource. And if anyone has any questions about rapid testing devices or implementation of a rapid testing program, please reach out to OraSure and you can be connected with a member of our diagnostics team.
Thank you, Rebecca. Appreciate that. We do have 5 minutes left, so we're going to answer one audience question. And y'all, I have 2 pages that I've logged of all your really fabulous questions. And I just want y'all to know we are going to follow up on all of them because you have some really great points and questions, and a lot of you are looking for resources. So we will follow up on those questions after the fact as a team. But we'll end on this question. So whoever wants to take it first. So the question is, while waiting on results, how do you utilize the time with the patient or client? If a result is positive, what does the workflow look like for confirmatory testing? What do you do in the meantime, and what issues have you had with loss of follow-up? I'm not sure who wants to take that one. That was a lot of questions in once.
So I'll go ahead. I think while you're waiting for results, as I mentioned before, talking about PrEP is really a key piece. Prevention is such a key part of what we should do as far as life. And then, we also want to talk about, if this test is positive, then we got to look at a confirmatory test. Then we also want to talk a little bit about possible treatments depending on the situation. Maybe we talk a little bit about, when was their last negative? So there's a lot of things you can touch on. If the person is negative, as I mentioned, you talk about PrEP, then you talk a little bit more for me is how do you keep yourself safe? How do you keep yourself from not getting infected, not with just HIV, but with other STDs as well? And then, the education piece about the other testing for me is the other thing, as I mentioned, we want to make sure that if they've not been tested for syphilis or hepatitis C, we look into possibly doing that at that visit as well. We don't want to leave them thinking that they got tested for everything when all we've done was just the HIV test. If we're able to give them those choices again, then we want to be able, or I want to be able to provide that for them.
Thank you, Jesse. Rye or Rebecca, I'm not sure if you have anything to add.
Yeah, a lot of similarities with what I do, kind of in that downtime waiting for results. I talk with a lot of folks about like PEP and PrEP, but also for folks who do identify like during the pre-screening that they use drugs, needles and drugs. If they identify that, I do also talk about and try to educate on like where can you access clean, safe supplies if you need that. And what does that look like, and how can we get you access to these, or PEP and PrEP if possible. And I think a big thing in that too is like Jesse said before, knowing your resources and knowing what's out there and available. I try to be as familiar with resources because the county, St. Louis County in itself, not just the city of Duluth, I work within this county, and it is so big that, if I get somebody who lives up on the range, looking at Minnesota, that's talking about like Hibbing, Virginia, Twig, all of those places, like a lot of folks up there don't have access to like a Planned Parenthood, and they don't have access to like a syringe program that is there. And so letting them know what their options are for these things and where they can get affordable care and stuff. I think too, a lot of that downtime is just talking, and the flow varies with people. What happens if a positive reaction comes from one of these tests, and what does that mean, and what are the next steps? Sometimes I get folks who are like, okay, I want to know what all of my treatment options are and what they look like. And some folks who are like, this is a lot of information. I just need to know like what my next steps can be. And so that's a lot of kind of what we talk about. And furthermore, like connecting afterwards, calling to check in, that kind of stuff, but also letting them know like, here's where I'm located. You can call me, you can text me. You can add me on social media if you need to add me and you have questions and you can't find like my business card or anything. And, I'm here to answer your questions if you have them.
And I'll just end really quickly with both Jesse and Rye. pointed out some of the absolute benefits to being able to have a little bit of time to provide some education while tests are running. And I hear that across the board from various different sources, that it provides a lot of extra ability to talk about harm reduction and next steps and everything else. So it's good to hear that.
Absolutely. Well, thank you so much to our fabulous speakers, Rye, Jesse, and Rebecca. We appreciate you all for being here and sharing your experience and your wealth of knowledge. Like I said, this recording will be shared after the fact so the audience can access that. And we are going to do our best to work through all of these incredible questions that you've dropped in the chat and Q&A box. We want to make sure that your questions are answered. So thank you so much, and I hope everyone has a great rest of your day.
Thank you. Bye.
Thank you.